you to, if you can, mute yourself if you're not talking, so we don't have that extra noise in the background. There are two basic ground rules. Only one person speak at a time, so just be respectful of one another. And the second one is, if discussion around a specific question goes beyond time, I'll just give you a signal, and we whoever's speaking can, have 15 seconds to wrap it up. Okay, so now I'm going to introduce our speaker. Dr. Jerilynn Prior is an award-winning endocrinology clinician scientist and professor at University of British Columbia with over 45 years of expertise. She's known for her groundbreaking work on estrogen-progesterone balance. Dr. Prior's innovative approaches are transforming the understanding and treatment of women's reproductive health. In 2002, she founded the UBC Center for Menstrual Cycle and Ovulation Research, and in 2003, she launched its informative website. She has a section on there called Ask Jerilynn, so you can ask questions later after this. Dr. Prior is an internationally recognized thought leader with over 300 influential publications on menstrual cycles, ovulation, PCOS, perimenopause, menopause, and osteoporosis prevention. Growing up in Alaskan fishing villages, she earned an honors MD from Boston University in 1969 and became a Canadian citizen in 1983 due to her belief in universal healthcare. I often refer to Jerilynn as the Gloria Steinem of medicine. She is just remarkable, such a great role model. So if you have a chance to actually work with her in in an academic way, I completely recommend it. She's just so awesome. So, Jerilynn, I'm going to hand it over to you to introduce yourself if you'd like, and pop up your PowerPoint.
Unmute myself. After that, I think I need to give my head a little pop, and so it'll come back to normal size. Thank you, Tricia. I should start off by saying that I'm a learner, and much of what I know about practical things are because I've paid attention to what women say. And I want you to accept that what you say and what you can observe is important. I have a nephew who has type 1 diabetes. I have a sister who has type 2 diabetes, who's on insulin. So I'm not unfamiliar with the field, even though I haven't been working with people with diabetes for over 40 years now. And I should also say that in perimenopause, I was looking like I was going to be a diabetic. And I said, no bloody way, and changed the way I ate and the way I exercised. And since then, I've kept my hemoglobin A1C at 5.2 or less. So I believe in the power of understanding and paying attention to diet, exercise, and all those things. So I know that's not enough in type 1 diabetes, but I wanted to give you that perspective. So let me share my screen here. And I just want to start with a couple of slides so we're all on the same page. So this is the website for SEMCOR. And I want to say that I acknowledge and am deeply grateful to the care of this land that the Coast Salish peoples have provided over the decades and decades. I don't have any commercial conflicts of interest, and I think that progesterone, this is a polarized light micrograph of progesterone, is beautiful. So why would you start off talking about the menstrual cycle with a calm moonscape? This is actually taken from near our cabin in the wilderness on Valdez Island. And the reason is that both metabolic control in diabetes and the menstrual cycle are affected by our emotions, by the stressors in our lives. And it's important to understand that is true in both situations. So I want to start off talking about the two hormones, and you're not expected to be an expert in them, but I want this to be a perspective that you understand, which is that we hear about estradiol or estrogen. Estradiol is the premenopausal form, all the time. And we rarely ever hear about that other hormone, progesterone. Now, I think the heart of what I'm trying to explain to you is that both are important and that they are partners. They're holding hands in a system within the menstrual cycle, but also in our physiology and our health. And yet they're as different as they could be in many, many, many ways. Estrogen is a powerful growth stimulator. It can make any cell of any sort grow. You put a drop of it in a petri dish with any cells and they will grow. And they continually grow, which is called proliferation. So progesterone is quite different. They're both steroid hormones. And its job is to make the cells become more grown up, if you will, or mature. But it also has a secondary job, which is to rein in estrogen's growth. And if you think about that, what happens when growth continues and continues and continues? There's chance of mistakes, genetic mistakes that can lead to cancer. So it's serving a protective role by partnering and by being in balance with estrogen. Now, how do these fit together in the menstrual cycle? And this is a simple diagram, much like you would see on Google if you put in menstrual cycle images or Google images. So the pink universally here is the estrogen, and it starts from low during your period or flow, and it rises gradually over the first week or so to reach a peak. And then it drops a bit and goes up to a second peak before dropping down to a low again during the next period. So you can see that estradiol is there for almost all of the cycle, although it's normal to be low during flow. And in fact, that level during flow, if by accident you went to get an estrogen blood test and you happen to start your period the next day, it might come back and imply that it was low, but that's perfectly normal. Okay? All right. So progesterone is low for the entire first half of the cycle. And after the estrogen peak, there's a pituitary peak called LH, which triggers release of an egg. And only after an egg is released does that, where the follicle got ruptured from, start making a new hormone, which is progesterone. So progesterone rises to a peak and then gradually decreases like estrogen before the next flow. Okay, now this is the kind of diagram that you will see. Are there any scientists in the group? Is there anything you see that might not be quite so cool with this picture? Anybody? Okay, that's all right. What I notice is it doesn't have any units. And the picture that most people, including scientists and gynecologists, have in their head is this picture, where estrogen is the dominant hormone of the menstrual cycle. It's the high one. It's there all the cycle. But that actually, and I made it small here, at the bottom here on the right is a more accurate picture in terms of amount. And now we're looking at the physiologic information, but plotted as percent change from their low during flow. Estrogen rises about 200%, but progesterone rises 1,400%. And it needs to be that high, and it needs to be for 10 to 14 days in order to do its job, which is counterbalancing the actions of estrogen and maturing tissues. So this is accurate information, and this is really a myth. Okay, so what do we mean when we say ovulation? So this funny looking thing, and I'm sorry, those of you who know French will be happy, but it's in French, but I can show you anyway. So this is a diagram of the ovary, and there's blood vessels coming in and it's anchored down, etc. So here's a large growing follicle, and there's a whole mess of very small ones here. And the big one that's about ready to release its egg is called the dominant follicle, or the Graafian or de Graaf follicle. And what's fascinating is this is a real picture inside a woman's abdomen with a scope. This is the surface of the ovary. You can see that follicles pooching out, and here's the egg actually being released. That's pretty amazing. The problem is that we don't know that an egg is released. And this is the only kind of proof that ovulation ever occurs. And most of the time, we cannot know. And that's one of the things that I think is not okay today, because I think a woman with diabetes who's having periods needs to know when she ovulates in order to manage her insulin and to avoid high and low blood sugars. Now, another myth is this: each month, one of the ovaries releases a mature egg. Well, that doesn't happen predictably. If we're under a lot of stress, we may well not ovulate in a cycle, and our period may still come in a regular way. I guess you'd say that's controversial, and there are gynecologists who say a regular period is always one that an egg is released from, but that's not what the evidence actually shows. Now, there's one other wrinkle in this getting complicated story. I'm sorry. So each one of these rectangles is a cycle, let's say, and so they're the same length. You can have a perfectly normally ovulatory cycle with a long luteal phase, 14 days or something like that. You can have one where an egg was released, but the luteal phase is short, so there's less time for progesterone to do its work. That kind of a short luteal phase is associated with having trouble getting pregnant. And you can have a similarly regular cycle that doesn't feel different to most people, that didn't release an egg at all. And although the mythology is that you're going to have a funny cycle if you don't ovulate, that is not what the evidence shows in healthy people. Okay? So the combination of either not ovulating at all or a short luteal phase, but within a normal length cycle, is called silent or subclinical ovulatory disturbances. And they tend to be more common in women who have stresses, women who have physiological instability, as in changes in blood sugar. So this is a really important thing for you to learn about. Okay, so here are real data where estrogen is in picograms or picomoles, and progesterone is in nanograms or nanomoles. They're actually in different units. And the unit for progesterone is 1,000-fold bigger than a unit for estrogen. So our bodies are making this huge amount of a hormone for a reason. We wouldn't waste energy doing it otherwise. And I'm going to leave this slide up for a bit because I want to talk about what happens when progesterone rises to your appetite, your insulin requirement. Because the evidence, and this is not clearly identified, but I did studies with a group of women with good control and type 1 diabetes 40 years ago that showed that once they ovulated, and they were tracking ovulation using a quantitative way of assessing basal temperature. And by the way, that method is available to you on the SEMCOR website. It's free and we validated it. So once the progesterone starts rising, our temperature, our first morning temperature goes up. Not very much, like 0.2 of a degree Celsius, which is a tiny bit, really. But when our temperature is higher, we need more energy. And the body is pretty clever because most of the time, we don't even know we're eating more. So with a nutrition scientist at UBC, Dr. Bard, a number of years ago, we studied women and they did 3-day diet diaries early in the cycle, and they did 3-day diet diaries at the end of the cycle. And we found that those who had ovulated were eating about 300 kilocalories more per day. That amount of increased appetite in order to keep, and their body weights weren't changing. The body weight of each of the women was stable over that cycle. That amount of increased appetite and intake was needed because of the energy requirements, since temperature is raised by progesterone. So you need more insulin when you eat more. You all know that better than I do. But the danger then becomes when you get, remember that the progesterone then goes down to very low during the period. If you don't know when your period is about to start, you may have an extreme low because you're still eating more and you're taking more insulin, but you don't need that. You're taking too much insulin for the amount of energy now. So again, these are things that if you want good control, that you need to know about your own menstrual cycle. So the other thing that I learned from this group of women was those who had very uncontrolled, wildly swinging highs and lows usually didn't ovulate normally. And we couldn't see that same change in their blood sugar and their insulin and the food that they were eating. So in other words, you will only see this if your control is good. All right. One more big picture thing, and that is that once you have a low blood sugar, there's a whole endocrine host of things that happen to protect you, to prevent that going on for very long. And one of the big things that happens is that there's prolactin and growth hormone and like cortisol and central norepinephrine all go up. And all of those hormones increase the blood sugar, and they increase them over a longer time. So if you've had a low and then you're high, don't keep adding more insulin to try to make that better. Your body has tried to protect you. That blood sugar level will come down as your response to that low recovers. I guess the message I'm trying to say is try to avoid low. Try to avoid a crash during your flow, right? Okay, so now, with that as a bit of a background that we can share, let's go to the questions.
Okay, Jerilynn, can you take down your slides so you can
Sure.
see people's faces
Absolutely.
when they...
Yep. Oh.
Okay, we have a preponderance of questions from a small number of people, so feel free to also enter your questions in the chat box. But let's start with this one. This is from Annan. Why is the topic the menstrual cycle not reviewed when you're first diagnosed, or in your first set of appointments with female patients?
Very, very, very good question, because it's essential for understanding. But I'm afraid that even my colleagues in endocrinology who take care of those with diabetes who are women and have cycles aren't very familiar with how these hormones work and how the menstrual cycle works. And also, I always think that it's most important that you know. You're the best expert on your own cycle. So I would like to inform the endocrinology colleagues of mine who manage diabetes. Unfortunately, they usually ignore that.
Annan, do you want to follow up?
I thought it was anonymous.
Oh, is that anonymous? I thought it was Annan.
So. I think so. So whoever doesn't want to be identified, fair enough.
Sorry, it didn't say anonymous, it said Annan, and I just figured it wasn't someone's name. Okay, so whoever asked that question, would you like to follow up? Okay, so question number 2. How does the menstrual cycle affect blood sugars, for example, insulin sensitivity and resistance throughout the course of a cycle?
Okay, so I partly told that already. In the days when I was doing that research and I wasn't measuring insulin, I wasn't measuring insulin receptors and all of that stuff, the message was progesterone causes insulin resistance. And I don't think so. I think that the requirement for more insulin is simply because the energy intake is increased. Okay, so if I were to guess the most important influential factor related to insulin resistance, I would guess estradiol, because estradiol makes us store energy as fat for lean times. And I mean, that's one of the metabolic things that it does. So I guess you might say there's some debate about that, but no longer do we think that progesterone, well, most people don't, that progesterone causes insulin resistance.
Okay, we have a follow-up from Marcy. Would you like to read? I mean, would you like to ask it, or I'm happy to? Okay, so I'm going to read it, and then Marcy,
Okay,
feel
go ahead.
free to jump in. Oh, I'll read it, and then you can jump on in. What if you're on an IUD and no longer have a flow? What is the best way to track your periods?
Actually, what is the best way to track your menstrual cycle hormones? Because I'm thinking that the IUD is the typical ones nowadays, which is releasing a progestin, a relative of progesterone, but a synthetic one, into the lining of the uterus. So it prevents the flow, but it doesn't prevent, as far as we know, the cyclic changes in hormones that we just talked about. So in someone on an IUD, if you really want tight control, I would track your basal temperature and see if it's going up or not in any kind of a cyclic manner. Otherwise, it's pretty difficult. Here's a clue. One of the best signs of high estrogen, and sometimes the high estrogen mid-cycle peak is high enough to give us breast tenderness. But when estrogen is high, our breasts will be tender. I'm going to stand up a bit so you can see what I'm doing here. So push the flat of your hand directly over your nipple and toward your spine. And if that's tender at all, it means your estrogen levels are high. So you can track if estrogen is high, but if you have a hormone releasing IUD, it's very difficult to track what's going on with estrogen and progesterone.
Marcy, do you have follow-up questions based on what?
No, that's the only thing I follow is if my breasts are tender.
Okay.
Yeah, thank you.
Mm-hmm.
If you were to measure your basal temp, would you just do it the same time every morning?
Yes, and so again, if you go to the SEMCOR website that I showed you before, it's just cemcor.ubc.ca. And in the middle of the main page, toward the bottom, is track your temperature or track ovulation. I can't remember what it says. But it basically, what you do is to add up all the days on which you have temperatures. And then you divide by the number of days, so you get an average temperature. And you can see where your temperature goes above and stays above that average. So when it does that, it goes above the average and it stays up there for a period of time, 4 days or more. That's the luteal phase or post-ovulation phase. So you can track your luteal length that way.
Okay, next question from Anonymous, not Anon. How do birth control pills affect everything you've been telling us about?
Good question. So in order for, I like to call them combined hormonal contraceptives because there's a pill form, there's a vaginal ring form, and there's also a patch form of the same group of hormones. So the kind of estrogen in the birth control pill is called ethinyl estradiol. It's a synthetic and it lasts 4 times longer than our own estrogen. It sticks around longer. It has to be higher than our natural level in order to prevent pregnancy. So the birth control pills typically contain 4 times higher than our own estrogen and about the same amount of a synthetic progestin as our body would make in an ovulatory cycle. When you go onto a pill, you'll require more insulin. in order to have your blood sugar remain normal. It is high enough that it alters your insulin and diet requirements. So I don't know, anyone who is still a teenager, I don't think should take the pill. For one, because it's associated with a longer time to develop a normally ovulatory cycle. But the second thing, and this is something, again, most people don't know, is that it prevents peak bone mass. We reach a peak about age 19 or so of the highest bone density we ever have. And the rest of our lives, we're either maintaining or losing that. And if we don't achieve a high peak bone density when we're teens, then we're at greater risk of breaking a bone later. So the birth control pill is not a good choice for someone with type 1 diabetes, especially if they're an adolescent. And in fact, if you were, I'm going to follow up on that because I just had a thought. There is the lower dose progestin releasing IUD called Kyleena. And after about 60 days or whenever, if you get a regular period, then you can start to track what's going on. So I would urge someone with diabetes to use the lower dose of the progestin releasing IUD so that they would have at least periods to track.
Okay, there was a follow-up question in the chat. If someone has insulin resistance already, is the birth control pill not a good idea since it increases? Oh, I just lost it. It increased the resistance even more.
I don't think it's a good idea in general. But it's particularly not so good in adolescence. I mean, there's many choices now. We didn't used to have those choices. And if you're in a stable relationship, using a barrier and spermicidal jelly is probably a more physiologic option. And then you can track also your ovulation or not.
Okay, with the person who submitted that question, Krista, would you like to follow up? Okay, I'm going to read a question from someone who did leave their name, Stephanie P. As a parent of a daughter experiencing pre-puberty, will we notice spikes in blood glucose before her period actually arrives?
Yes, I think so, because the estrogen levels are starting to rise and they're unpredictable. And in fact, if you were to be able to look in a preteen abdomen, the ovary is getting bigger and it has a whole bunch of cysts in it. And in fact, if someone had some reason that there was a surgeon inside your belly when you're at that age, they wouldn't be able to tell that ovary from someone with polycystic ovary syndrome. So in other words, there's a lot of hormonal activity that happens before we get our first period. And it would show up definitely in increased insulin requirements.
Okay, we have another question in the chat box. Is there a form of contraceptive, and I know you had mentioned something already, but is there a form that you'd recommend more for people with type 1?
Well, like I said, I think the lower dose, which is Kyleena, is preferable to Mirena, which is the higher dose one. And if you can manage with the combination of a barrier and spermicidal jelly, it's better. I for one, tried the birth control pill in the 60s when it was a super high dose. So now the levels are 20 micrograms or 15 micrograms. And in those days, it was 100. and it didn't agree with me at all. I got my first migraine and swelled up, so I couldn't take it anymore. And when I was reproductively mature and with a man, I used diaphragm and jelly without any misses. So it's possible to do that, and then you're not making any changes in your own hormone levels.
Okay, another question in the chat box. Is there a higher risk of endometriosis with people with type 1?
That's a good question. I do not know the answer. I will look it up, but I don't know it.
Okay, next question. What's the difference between PMS versus a period affecting type 1?
Well, okay. So PMS is another one of those things about which there's a lot of controversy. I guess I would explain it this way. Progesterone has an effect, especially in some people, of making us more sensitive or aware or perceiving things that we might be able to not see otherwise. And if you combine that with a higher estrogen and you're under a lot of stress, we tend to blame the emotions that come out on the hormones. Almost always there's a lingering argument with a boss or a partner or something, conflict going on, or worries about finances or something. And it's like once a month, it's in our face, we have to deal with it. So my approach to premenstrual syndrome is, one, to try to figure out what's troubling you, agree to deal with it, not before your period, but later when you're feeling better. Sorry, Trish, I'm not a psychologist. And say to those around you when you're being, grumpy and unreasonable, it's not your fault. It's, it's just the way I'm feeling right now. And if you do need to deal with in a conflict situation, frame it as I feel, because nobody can argue with how you feel. I feel such and such a way. In other words, so you're not making a big blaming thing, which doesn't help anybody. But you're just saying, this is the way I'm feeling right now. And if you can, make an agreement with that person or with yourself to deal with it when you're feeling better. Now, that's one part. The other part is that again, often with women with type 1 diabetes who were keeping excellent records, learn that if you increase the amount of physical activity you're doing, even a little, from not regularly walking to regularly walking, for example, it decreases the emotions you feel before your period. So it's an option, and it's part of a toolkit that you can use to deal if you're dealing with premenstrual symptoms. The other is pay close attention. If you're getting breast tenderness before your period, that's a time when it should be low, right? It suggests that you're not ovulating, that your hormones aren't right. So you can use that as a way of figuring out if the cycle is normal or not.
Hey, we have.
Did that help? Whoever asked.
It was Anon again.
Oh,
all
okay.
right. That ain't on. All right, so we have another question in the chat box. Can you talk about ways to mitigate insulin resistance when you have irregular cycles because of PCOS?
It's an interesting one. Okay, a little story, if I may. When I first started as an endocrinologist here in Vancouver, I'd had a year of research training, and I'd had a endocrine research training and a year of endocrine clinical training, but I really didn't know how to manage menstrual cycles, and I hadn't been trained in women's reproduction. And the first people that I saw, almost everybody had hirsutism or PCOS or both. And so I said, I don't know quite what I'm doing, but I'll do some reading and find out. And what I learned very quickly was that PCOS was associated with an increased risk of cancer of the lining of the uterus, endometrial cancer. And so I thought, okay, I know what makes that better, and it's progesterone. And also the periods were far apart. So in those days, we didn't actually have oral micronized progesterone, the natural hormone. We only had medroxyprogesterone, or Provera, it was the brand name. And so I would explain to my patients, I think taking medroxyprogesterone for 10 days, I don't know why I didn't do 14, but anyway, 10 days each month should give you a regular period, and it'll decrease your risks for endometrial cancer. And I asked if they wanted to try it. I said I couldn't, there wasn't any literature about this. I reviewed it. These were the things I thought would work. And they did. And I was quite amazed at how incredibly better these women seemed to be. And it wasn't just that they got more predictable periods. And I mean, they got better enough with regular periods. Their facial hair got better, the acne got better right away, and within months anyway. And they just felt better in themselves. And some of them, they would delay starting the medroxyprogesterone, and sure enough, their progesterone levels showed they ovulated themselves. And if they weren't taking an androgen blocker, they could stop the progesterone, and they were able to continue to have regular periods. And we now know that that changes what's fundamental in PCOS, which is rapid pulsing of that LH hormone that we talked about, because progesterone naturally slows it in the menstrual cycle. And when it slows down, then ovulation can occur. Then there's no androgen production in excess, and women get better. It's almost like they don't have PCOS. And we've just completed a 6-month study in which everyone was taking cyclic progesterone. And we asked them at the beginning about their quality of life. And at the end of that 6 months, their quality of life improved 42% on average in 6 months on that therapy. So now I forgot your question, but
Insulin resistance. So does progesterone have an impact on insulin resistance? Will it help reduce insulin resistance
I don't
for people who have PCOS?
know for sure, but it will help if you don't eat that 300 calories more and you need to lose weight. It will help you lose weight. And if you adjust your insulin to the amount of food you're eating, then you should get better control. And if you get rid of PCOS by doing that, that's a bonus. We haven't studied blood sugar and PCOS and in together, so I don't know about that.
Okay, the person who asked that, did you want to follow up?
It was me, Trisha. I don't
Kim.
know if I have a follow up. I guess it's just more of an observation. Like I actually I did try progesterone almost a couple of years ago, but I only stuck it out for 3 months. It didn't really sit well with me. maybe I'll give it another shot. But I just like find, I guess my frustration is it's really hard for me to control my blood sugars when my cycle is unpredictable. It's not like I have a 28-day cycle, so I can't like at day 14 be like, okay, I should up my background and my long acting at this point. It's almost like I have to wait until it's bad to do anything about it when I'm trying to have very tight control and get ahead of it.
Right.
So
Kim,
yeah.
Do you remember how much progesterone you took?
No, I don't.
Was it one round? They're like a little ball.
I think it was just one tablet.
Was it a little ball?
It was a little white ball. Yeah.
Ball, okay. It takes a dose of 3 of them to be equivalent to the normal luteal phase. So probably it wasn't enough to adequately help you.
Are there any like negative side effects to taking potentially?
The biggest side effect of taking progesterone, well, there's 2. One is that it costs a lot. It's really inappropriately highly priced. But the second one is a good one in that if you take the progesterone at bedtime, it helps you have a deeper sleep.
Okay. Okay, that's interesting. Thank you. That's like I hadn't, like I said, I kind of wrote it off after I tried that a couple of years ago, and I don't know why, but it just didn't sit well with me, and then I just kind of I gave up on that. But maybe I'll revisit that with my doctor.
It should give you at least more predictability.
Yeah. Thank you.
So there's an article on the SEMCOR website about managing cyclic progesterone. It's not written for PCOS in particular, but it shows you that if you, for example, start bleeding while you're still taking the 2 weeks of progesterone, that you should carry on and finish the 2 weeks and then start the next cycle from the day of the first flow. So you end up being on progesterone for a few days longer early on because if often there's higher estrogen that you need to cope with. Yeah.
Thank you.
Okay. We have another question in the chat box. This isn't really diabetes related, but when I was newly diagnosed with hypothyroidism or Graves' disease, my breasts were sore so much. My doctor and endo didn't really know why, or they didn't even seem concerned. But is there a connection between hypothyroidism and estrogen levels?
Interesting. In general, when people are hyperthyroid, they are skinny, they're metabolizing food really fast, their temperature is higher, etc. So I wouldn't expect normally to get breast tenderness in that situation. But the interesting thing is that we did a randomized controlled trial in which half of the people got progesterone and half got a placebo, and I didn't know who was on what, and measured thyroid hormones, and TSH and free T3 did not change, but free T4 went up a tiny bit on progesterone compared to placebo. And I think the reason is that during pregnancy, it's super important for the fetus to be exposed to an adequate amount of progesterone. And so this is kind of a fail-safe, progesterone increasing free T4. And the mechanism by which it does that, I don't know, because normally TSH would make more thyroid hormone, but it wasn't increased in this situation.
Okay. Does the person who put that in the chat box want to follow up?
No follow-up, but I just want to thank you because as soon as you said that like estrogen affects breast tenderness, I was like, oh, I wonder if that has to do with it. Because it's something that, like I said, my doctors very much were like, I don't know, you're fine, go home. And I was like, alrighty.
So those two hormones counterbalance each other. And so you're more likely to have breast tenderness if progesterone is low.
Yeah,
Right.
that's fascinating. Thank you.
You're welcome.
Okay, I'm going back to the pre-submitted questions from Anon. Does the menstrual cycle ever affect type 1 in a positive and beneficial way?
Yeah, I think so, because one is I mean, if you're tracking it, it allows you to predict when you're going to need more insulin, especially if, as most of us do, you, without realizing it, increase what you're eating. But if you do not increase what you're eating, if you make a point of not doing that, then you should be able to lose weight if you need to. I think that's positive.
Okay, does anyone want to follow up on that? All right, there is another question in the chat box. Is estrogen around the period cycle the main cause of period-related insulin resistance? I may have missed this earlier, but wanted to ask for clarification.
I don't quite know what you mean by period-related insulin resistance. You mean cycle-related? I think estrogen increases insulin resistance at a practical level. I think that's also controversial. General assumption is that, well, for example, in treating menopausal women, those women who are on menopausal hormone therapy, which is estrogen dominant, tend to lose weight versus those women who aren't in randomized trials. So it's confusing, but of the two hormones, I think it's more likely that estrogen is associated with insulin resistance.
Krista, do you want to follow up on that? Okay.
She said,
I
thank
forgot. All right. Could there be a connection between the menstrual cycle and erratic blood glucose levels? If so, how is it?
For sure there's a connection. For sure there's a connection. And it's a two-way street, really, because when your glucose is out of control, you're feeling, unsure of yourself, you're not feeling well sometimes. And that not feeling well is a predictor of not ovulating normally. The one thing I've learned is that having a normal luteal phase length and ovulating is an expression of in the broadest way of health, emotional well-being, physiological well-being, social support, nutritional adequacy. It's a very subtle but an important marker that things are okay with that individual woman when she's normally ovulatory. Again, sorry, Trish, that's
Does someone want to follow up on that? Okay, next question.
let me just
Sure.
back that up a little bit. During the pandemic, we did a one cycle study with 108 women, and we had done a similar design study 13 years before. Similar recruitment, similar age range, similar cycle lengths, both time periods. But during the pandemic, a third of all the normal length cycles weren't ovulatory, and another third had short luteal phases. That suggests to me that the women who participated didn't have COVID and they hadn't just had a shot, but just the stressors that we all felt of being shut off from other people, not knowing what was ahead, wondering if our loved ones were going to get sick and all that, all those kinds of changes I think we're enough to cause this huge increase in disturbances of ovulation, not cycles, but ovulation in these healthy 30-something women.
Okay, next question. This regards hormone replacement therapy and CGM on the arm. I use estrogel on my arm twice a week and want to know if there are any issues using it in the same area as my CGM.
Okay, for a start, I don't know if we're talking about perimenopause or menopause here, but I would say don't use it in the same arm as you're doing the CGM monitoring. Put it somewhere else on another, on a tummy or a leg or something.
Okay, the person who submitted that, would you like to follow up? All right, next question. How does, I know we're coming on to 7 o'clock, so if people, Jerilynn, are you okay with staying a bit longer to finish up? There's about 3 more questions. Okay, if you need to leave, thanks for showing up, but we'll just keep finishing the pre-submitted questions. And again, if you have any questions, burning questions right now, just put them in the chat box or raise your hand and you can ask. All right, so next question is, how does hormone replacement therapy impact blood sugars?
Impact what? Blood sugar?
Blood sugars, blood
Okay.
sugars.
I would like to talk about that when we're talking about
Menopause.
perimenopause and
Okay.
menopause, because
Okay.
yeah.
All right, so sorry, that got through. That question got through into the all right, so I guess this is the last one of the last questions from Anon again. I was recently put on diagnosed for endometriosis and stopped getting my period. I also got put on estrogel for perimenopause symptoms. What can I expect with my blood sugars? My gynecologist said it shouldn't affect them at all, but the roller coaster of hormones during my cycle used to be my biggest challenge to control my blood sugars. Any insight would be helpful.
Okay. The hormone on which you were put is a kind of a progestin. It's strong enough to suppress both estrogen and progesterone in your cycle. And I really don't know exactly what changes you might see. And whatever you do, I would track the doses of both estrogen and the progestin and just experiment, because there may well be changes that you will notice. The other problem is that this person didn't say how old they were or if they were in perimenopause or not. And it's unusual to give someone estrogen if they have endometriosis. That is usually avoided because it makes the tissue that's like the lining of the uterus and now is in the belly itself, the peritoneum, it makes that tissue grow. So I wouldn't advise being on estrogen if you have endometriosis, but I'm not your doctor.
Okay, so I'm going to go ahead and open it up to everyone on screen. If you have a question, please feel free to just raise your hand and we can, I can have you ask it in person. Or if you don't want to ask it in person, feel free to put it in the chat box. But if I don't see anything, I'll just assume that we are done with our conversation on the menstrual cycle, and we will see folks in the next part 2 for menopause. Okay, it's Nicole, do you want to ask a question?
Yeah, I did submit one, but I didn't hear it asked tonight. So, what I wanted to say is that I do not get a period anymore, and I have been tested for perimenopause and was told that that is not occurring. And I'm 41. I am curious if my hormones may still be doing some changing in the background in some kind of cyclical fashion. regardless if I am having a menstrual cycle or not.
Okay, good question, Nicole. How long have you been without a period?
2 years.
Okay, and has any doctor ordered an FSH test?
That's a good question. I'd have to review my lab work, but I don't think they have, and I did see a gynecologist.
Because it should, with that long without a period, it should definitely tell you whether or not the problem is, well, whether or not you've entered into menopause, which is slightly early, or whether there is something else that's interfering with your period.
Okay.
And if you're otherwise feeling well, you're not stressed out of your mind, you're not ill, you're not losing weight like crazy or something, it's probably a bit early menopause.
Okay.
And it's important to find out because just so you know, most people would use natural hormones in physiologic doses for someone with an early menopause.
Okay.
Until the average age at menopause, which is in 51, 52.
Because of the loss of bone density, right?
Yeah.
Yeah. Okay.
Well, those hormones, they work everywhere in our bodies, in our brain, in our bones, in our breasts, in our, everywhere, our cardiovascular system. Yeah.
Okay.
Jerilynn, doesn't a hormone panel, wouldn't that indicate or demonstrate whether someone is in menopause or not? Wouldn't the results in a hormone panel kind of be the,
Nobody should be ordering hormone panels.
I mean,
Really?
in terms of,
Yeah, because you don't measure a hormone unless you are going to do something with the result. And the fact that she's been without a period, if she's in menopause, the FSH should be high, quite high. And if she's not, then it will be in the normal range.
Okay, I'll have a look. Thank you.
You're welcome.
okay, any other questions? Becca, I see your hand raised.
Yeah, I just am wondering. I know I've been learning about this in my biopsych class and in my biology class, and just talking about bone mass and with applicable to brittle bones as they get older. Do you find there's a correlation with diabetics and brittle bones as well? Like, I'm wondering, as a young diabetic, is there something that I should be doing now to prep my body for the future? And if my diabetes plays into that at all?
Good question. Okay, so remember I said estrogen and progesterone are partners, work together. Estrogen prevents bone loss and progesterone promotes bone formation.
Okay.
So that's another reason why ovulation is important. So worth tracking, worth trying to understand for yourself. The other is, if you look on the SEMCOR website, look at the ABCs of osteoporosis prevention in premenopausal women.
Okay. Awesome. Thank you.
So we had a question in the chat asking if I wanted to summarize what do I want people to take away. Should I do that now?
Yes, please.
Okay.
Yeah. Give us your pearls of wisdom.
Okay. What's important is that we are a complex of, people living in a social situation with a body which has needs for nutrition and exercise, etc., and that no hormone ever acts by itself. We need to understand that our insulin requirements are related not just to our energy intake and energy output, but also to the hormones in our menstrual cycles, which means we need to understand about whether or not we're ovulating. And those with type 1 diabetes are at increased risk for osteoporosis. And it isn't, or for breaking bones, actually. And it isn't entirely clear why. But my hypothesis is that it's because of intermittently not ovulating, as you know, blood sugars go out of control for various reasons, that we simply haven't built or maintained a high bone density.
Okay, great. Thank you. We want to thank you, Jerilynn, for joining us for the huddle and sharing your knowledge. I think I want to say one thing that Jerilynn said at the beginning. It's important that you feel like you're listened to. If you talk about symptoms and you are kind of shooed away or dismissed, that's not okay. So, I'm going to speak for you, Jerilynn. Like, if you have a question about your woman's health, Jerilynn is so one of the most gracious people I know, just like Jerry is, and just ask her, because she's a person who is going to sit and just listen to what you have to say, and that's, as you say, the most important thing, just to know what someone's experience is, because it's completely unique. All right, so next, I don't know what we're going to be hosting next month. Maybe will do our part 2 in menopause. But if you have any topics that you want us to host or to talk about at a huddle, please feel free to do that. I mean, the only reason we're doing this today is because 3 people had mentioned menstrual cycle in our last huddle. So feel free to let us know. We'd love your feedback, and thank you for carving out some time tonight. Bye-bye.
Thank you. I've enjoyed it.
Did you want to stay on, Jerilynn?
No,
And debrief?
I'm okay.
Okay.
Whatever.
Well,